microphones on. Excellent, thank you very much. And if we do get any problems with, I'm not expecting any, but sometimes Teams can be a bit difficult. The next thing is turn off your cameras, because that also helps with the bandwidth. But at the moment, there's no problem. So thank you very much for joining us today. And we've had a very positive response to tonight about health subject, and I'm pleased that so many of you could join us. Just by way of introduction, my name's Julia Clark. I'm the Director of Public Participation. We organise, we've got a whole programme of about health events that we run throughout the year. And tonight we're talking about patient experience. And I'm very pleased to welcome Ruth Smith, who's our Head of Patient Experience. Ruth has a nursing background. She's been in the NHS since 1990. So a long time, and has been at SATH since 2020, and has had a variety of positions, including sort of hands-on nursing as a ward sister and ward manager, and matron. Also worked in the improvement team, and is now part of our corporate nursing team, reporting to the Director of Nursing on Patient Experience, and more recently has become a member of the NHS Executive Heads of Patient Experience Network, otherwise known as HOPE, which I think is a rather nice acronym, leadership team. So thank you, and welcome, Ruth. Before Ruth starts, we are going to record this, and we do put this recording, we do publish this. I would ask that we, if you don't want to be seen, just switch your camera off. We do, Ruth, it's not a very long presentation, so I do ask that you wait until Ruth has finished the presentation before we get to the question stage, because some of the questions may actually be answered by...
So when it was time to come for a repeat prescription,
somebody's got their microphone
they said
on.
that there was nothing on the computer in the doctor's about
I think it's a video.
going into hospital, even though she got sent from the doctors.
Is that your video, Kate?
It was just a nightmare from then on.
Kate,
I kept going to the doctors
video,
because she couldn't get through on the phone.
I'll mute you, Kate. There we go.
Okay,
mute Kate while she's sorting it.
We've always wanted to do that.
You've unmuted yourself, Kate.
Kate, can we put you on mute? It's your YouTube video that's playing in the background, and it's coming up on the screen. So we're going to put you on mute, so as not to, and we will continue to mute you until that stops. So it is being recorded, so it will be on the internet and available to others. So today is really to talk about all of the strands that constitute patient experience and how Ruth and her team weave those together. So it's to give you that overview. It isn't to deal with individual cases. If there is anything of an individual or personal nature, Ruth can certainly, outside of this meeting, direct you.
We didn't have the doctor that was present who originally prescribed that medication.
I don't quite know what's going on.
I think that was Ruth. Yeah.
Oh, that was Ruth that time. Okay.
Yeah.
There is a YouTube video clip, and you've just heard two little bits of it, but we'll go straight into the presentation now, and I'll hand over to you, Ruth, hopefully without any more intervention from YouTube. Ruth.
Thank you very much. So yes, my name's Ruth Smith, and I'm lead for patient experience here within the trust. Julia referred to a team. Unfortunately, it's a very small team. It's just myself and a colleague, Sarah, who's part-time with me. But there is investment into the team. So I have got some new people that will be joining us soon. So lots of hopes and aspirations for how we can move patient experience forward even more soon. Kate, I think you've got control of the slides, if you don't mind moving it forward. Thank you. So patient experience is really hard to describe. So this is a definition from the King's Fund, and they said getting the basics right so that patients are treated as we would wish our loved ones to be treated, with kindness, consideration, and as individuals with their own needs and wishes. And then we've got another, on the next slide, we've got another definition, and this is from the Beryl Institute. and they describe patient experience as something that we've lived through. It's about something that happened, and it's our lasting story. It's defined in all that is perceived, understood, and remembered. And there are a range of definitions, but ultimately, patient experience is about how we make people feel when they're accessing our services and when they're leaving our services after being in hospital. If we can go to the next slide, Kate, that'd be great. Thank you. And I just wanted to see, we do have a chat, or if somebody wants to put their hand up, but if somebody would share when they received good customer care, and just share a bit of an outline about that. I'll give you an example for myself. I recently bought a new car, and the garage gave me a really good experience, and they made me feel very valued as a customer. I don't know whether anybody else has got times when they've perhaps felt really well looked after by an organisation.
Any volunteers, put your hand up if there's something that happened that you just thought, well, that was exemplary. They couldn't have dealt with me better than that. It doesn't have to be health related. You might have to cast your mind back. Anything at all? Oh, Edward. Oh, you're on mute, Edward. You can unmute.
I had a kidney transplant 16 years ago, and the care I got from in London, I thought was absolutely outstanding. They went all out their way to look after my family whilst I was ill in hospital at a very difficult moment in time. I got out on the other side, so that's why I've joined. So
that's really interesting, because you said it's how they looked after your family.
Yeah.
And that's often what it is. It's about how people make us feel. So they made your family feel special and important and seen. Yeah, and that's great. So that's often what people go away with. It's how we speak to people and how we treat people, and those are the things that they remember above everything else. They don't always remember the medicines that they were taking or the bed that they were in, or it's how people spoke to them, how they valued them. So thank you for sharing that. That was really good.
Thank you, Edward.
So there's different things that can affect how our experience is. Some of it could be the process. It can be what happened, or the steps that it took for us to get there. Some of it can be around the experience, as Edward shared as well, about how we felt or how they made somebody else feel. Because it's not always. It's about the patient, but actually it's about the people that are really important to that patient and supporting them on their journey as well. And it's how we look after those people. And also the outcome, so the end result, that can affect our experience too. If we can go to the next slide, please, Kate. So wrong way. I've just got a slide from the Beryl Institute, and they undertook a study in 2021, and they asked patients what matters most when you're accessing healthcare. And you can see the things on the left of the screen are what people rated the highest. All of these items were important, but the highest things are the things on the left that are in the blue circles. And all of those are how we made people feel. So it's about listening to people, how they were communicated with in a way that they could understand. Was the environment clean and comfortable? Were they treated with courtesy and respect? And did they have confidence in the staff and the people that were there? And that's a lot of that is around communication and the time that we take to explain to patients what their choices are, and put them in control of their care. If we can go to the next slide, please, Kate. So a lot of those things that were highlighted are within our gift to make a difference around how we talk to people and respect people and value people. But how do we get feedback from people? That was the Beryl Institute, but how do we get feedback from people in our hospitals and from our local community? And if we can go to the next slide. It's quite a busy slide because there's a big list of different ways that we get feedback from people. And some of these may be things that you don't understand in the terminology. So we've got friends and family test, and that's called FFT as well, quite frequently. And that's a national way of across NHS England of how we ask people for their feedback on their experience of care. And that's because NHS England recognise that every patient should have an opportunity to provide feedback. So we give out FFT cards. There's also posters in the hospital with little QR codes, because everybody with COVID has got more technology friendly, a lot of people. So you can use QR codes to sorry, I'm at work and the lights go off. You can use QR codes to take you to a survey, an electronic survey. There's the paper ones. You can access the friends and family test via our website as well. So there's lots of ways that you can feedback on that. And the feedback that we get on our friends and family test, all of the hospitals have to feed that back to NHS England every month. So there's a national comparator against other hospitals, so we can all see how each other are doing as well. We have national surveys, so we have an inpatient survey, there's a maternity survey, children's and young people's survey, urgent and emergency care, so that's for people accessing the emergency departments. So there's a range of different surveys, and those aren't sent out by the hospital. They're sent out independently, and they're reported on independently too. And other bodies will look at that information, and again, we can do comparisons against other hospitals at how we're doing and the feedback, what we're doing well in and what we're not doing so well in. We have local surveys, because a lot of those national surveys happen once a year. Some happen every couple of years. So what we've done is we've looked at the key areas within those national surveys that we need to do a little bit better on. And we need to be able to measure as we go along to see any improvements or deterioration. Those are local surveys. So they're surveys that are carried out by our hospital, but asking the same kind of questions that those national ones would do, so that we can monitor how we're doing. We also have compliments, and it's important that we learn from compliments too, because if we're getting things right, how can we share that practice? How can we make other people aware? And it's also important that we recognise when things are going well. We can learn from concerns. A lot of the concerns may be emails that we get, but a lot of that is from our PALS service. So that's our patient advocate and liaison service. And they pick up on things where people are a bit worried about something, or communication hasn't been great, or people just don't know where to go with a problem. So that's what the PALS team can do. And then any concerns, we can get the themes from that to pick up if there are certain areas that need more focus. And again, similarly with complaints. So if every complaint is an opportunity to learn, but also we can look at that as a separate complaint, an individual complaint, but we can also look at it as wider themes. So if there's a concurrent theme that's going through the organisation, then we can pick up on that quite quickly. Social media is again another way that we can get feedback from people. And exemplar assessments. So exemplar assessments are assessments that happen within our wards and departments, and a large number of staff are involved in those, because we look at lots of different things around how that ward is doing. So we'll look at the quality of it, the safety of it, people's experiences of it. We use people with certain knowledge bases, such as the infection control team are there, our facilities team are there, our health and safety team are involved, and we also look from a patient experience perspective, and often those questions can be identified through a patient representative or a volunteer, so they're having an open conversation and getting honest feedback from that patient, and if not, it can be a member of staff that seeks that as well. Other ways that we get feedback are from patient experience groups. So we've got a number of patient experience groups, and we'll go into that a little bit later on, but those are people that work with us, but obviously bring feedback from experiences perhaps of other patient people that they were there with in different groups outside the hospital. We hold stakeholder groups, digital stories, so sometimes those are referred to as patient stories as well. But digital stories can relate to a patient's experience. It can be from the viewpoint of somebody that was important to that patient, because patients can't always share their own experiences. So it might be from somebody, a family member or a partner, or somebody just close to that patient. And occasionally, but more rarely, it can be from a staff perspective. And again, it's giving insight into something that happened that we perhaps got wrong, or where there's learning that we can take from that. We get feedback from the Trust website. So there's lots of ways you can feedback from the Trust website. I mentioned about the friends and family test, but there's email. We often get emails, and people can leave their feedback in an audio form as well. So lots of different ways. There's feedback websites that are outside the hospital. So some examples of those are care opinion and NHS choices. So that's a little bit like sharing your feedback, a bit like TripAdvisor, but for hospitals. So it's about sharing your feedback and saying how what your experience was like, and it's visible there for everybody to see. And we also have feedback from external agencies. So some examples of those are the Maternity Neonatal Voice Partnership, there's Healthwatch that feedback to us, there's CLICE, and there's also CQC amongst other bodies as well. So lots of different ways that we can get feedback directly from patients, from people important to them, or from other stakeholders too. If we can go to the next slide, please, Kate. So how we use the feedback is equally as important. So feedback gives us obviously insight from a patient's perspective. We triangulate that to provide a more robust insight and an overview. So by triangulating it, what I mean is we compare what the patient experience is telling us to what the quality metrics are telling us, and then to safety as well. So we're not looking at things separately, we're trying to bring things all together to look at it more holistically to identify if there's a problem in any area. The image that's on the slide is one of the quality boards. So we have those outside every ward, and they're going into departments as well. And you can't see really from the slide because it's a really big board, but some of the metrics that I spoke about earlier, the friends and family test and what patients are telling us, some of those things are on that board with the quality data and the safety data. We've also got examples. You can probably just see the outlines of the speech bubbles at the bottom left of it. And that's an example of what a patient or someone important to them has told that ward and how they've used that feedback to make a difference or an improvement. So it's giving examples every month of how they're listening and responding to what patients are telling them. And all of these boards are updated on a monthly basis. There's also safety crosses there, again, to highlight about if there's been any incidents on the ward, and issues about learning, and also who to speak to if people have got a concern or a problem. So it gives a picture there of the ward manager. It gives a picture of the matron and tells you their names, so you know who to ask for. And it shows you a picture of the red armband. So that's for the nurse in charge on that shift. So you know who to speak to if there's a problem and you don't feel you're being listened to. So as well as triangulating that data, that feedback helps us to identify priorities and things that we need to look at, because if there's themes that are coming up concurrently, then obviously that's an issue that needs to be looked at further. It informs some of the improvement work. So I mentioned some of the patient experience groups. So some of that feedback that goes to them. So there's oversight on complaints themes, on PALS themes, on surveys, and on the friends and family test. And all of those themes can help identify what priorities are going to be worked on for each of the patient experience groups. So that helps to improve some of the services. It helps to improve on a higher level of what we're doing and what's important to us as an organisation. And also the feedback we can continually monitor. So we can see how we're doing and whether the improvements that we're putting in place are making a difference. If we can go to the next slide, please, Kate. So this is just to highlight really the importance of why we need to work with patients and people. So when we're designing a service as healthcare professionals, we can do what we think is the right thing and what's needed. But actually, it's the users and the patients and people coming into our hospital that will set something out different. So like this design, if they'd have engaged at an earlier point, maybe they would have got it right in the first place, rather than learn from observation and experience after. So that's why it's really an example of why it's really important that we involve and engage patients in design and development of our services. So I mentioned earlier about digital stories. So I've got a digital story here that we've got permission to share for learning outside the trust. And I think Kate's just going to put the link on just that we can listen to that before we move on. Thank you, Kate.
Might just take a moment or two, but here we go. Oh, no sound, Kate.
Okay, hang on a minute. I'm going to stop sharing and reshare. I think it's because something to do with my headset.
No worries.
You could hear it. You could hear it before, couldn't you?
While you do that, I will just say, if while we're going through the presentation, you think, oh, I really want to ask a question, put it in the chat, and I'll pick it up. You will get first question at the end of the presentation, because I know unless I write things down, I forget. A number of times I get to the top of the stairs and think, why am I here? So you do put it in the chat, and we'll take the questions from chat first before we go to the floor. And from having a YouTube video that wouldn't stop playing, we're now waiting patiently for it to start again, but it will only be hopefully a couple of minutes, well, a couple of moments while Kate just reboots it all.
So while we're waiting, I'll just outline digital stories, which this is. Give an example of how we listen and learn from patients. So some of them are more difficult, and some we've only got permission to share inside the hospital, which is why I've chosen this one to share today. But often we take those to governance meetings or trust board. Some patient stories go to. We use them in training and development. So it's how we can share that story so that other people learn from a person's experience, and we can make those improvements. So that's why I wanted to share that kind of learning with you today, because it's a different way that we get that experience and share it. Thank you, Kate.
We're all sitting here willing it to work. So if the power of kinetic, here we go.
Good morning, good afternoon, or even good evening, depending on
Oh
where
no,
you're
we don't want to know about
from.
female bladder leakage, Kate.
Welcome.
Well, not all of us do.
So I'm Jade. I work for the Patient Advice and Liaison team. I work predominantly at the Princess Royal Hospital, but we've got offices at both sites. And we assist all patients with all aspects of their care when they need advice and support. We also assist with accessing other care sectors as well in the community and where they need to go to do that. And we make sure that we're assisting them with communication between teams as well when that's sort of broken down or not going quite as they would need it to be able to move through the service as they would. Yeah, there's very little we don't help with. We don't help with legal claims or legal services, and we don't give medical advice either because none of us are medical teams. So we recently had a case whereby a patient had accessed the services of the emergency department, and upon leaving the trust was unable, with any support of any pharmacy teams, to obtain the medication she needed. And it wasn't a medication that she could just not take, so we needed to act really fast to make sure she had it and that she was supported in getting that whilst not present at the hospital. And we pulled together several disciplinary teams to make sure that we had all of the documents that we needed and all of the patient history we needed to be able to prescribe and provide the patient with the medication before she ran out, which was a huge panic for her and was resolved really, really quickly. Actually, as soon as PALS became involved, it was speedily resolved.
So my mother-in-law, she'd had racing heart and all different symptoms, and she was actually took in from the doctor's surgery. So when she was in 2 days, and when she got discharged, they didn't give her no discharge letter. No information was passed on to her doctors about this, and she was on new blood pressure tablets, a heart tablet, and a Pixaban, the blood thinners. So they were really important to her. So they said everything would go through, and nothing was relayed to the doctors, and she didn't have a discharge letter. And my mother-in-law didn't know that she had to have a discharge letter. So when it was time to come for a repeat prescription, she couldn't. They said that there was nothing on the computer in the doctors about her even going into hospital, even though she got sent from the doctors. And this just went on. It was just a nightmare from then on. I kept going to the doctors because she couldn't get through on the phone. You know, when you ring up for a prescription, you just can't get through. They said they'd give her a face-to-face consultation with the doctor the next day. She rang the next day. And this just went on for the whole week. And obviously you can imagine what my mother-in-law was feeling. She's got palpitations, bad heart. And this just made her worse. So I kept going into the doctors. No, there's nothing on the screen. Ring back tomorrow. And they kept promising. They sent an email to some health person about this prescription and promising that it'd be fine the next day. And they said, if we don't ring you back on the Friday, it'll be fine Monday to pick it up. Well, they didn't ring back, so we thought it'd be fine. And no, it wasn't. It still wasn't done. Nothing on the computers about her even going into A&E. It was just a nightmare.
We contacted all the doctors in A&E. We didn't have the doctor that was present who originally prescribed that medication. So we then had to go through the process of asking another clinician to look at all the history of the patient and make sure that it was safe and that's what should have been given, which it was. And we then escalated to ensure that we could get all of her discharge summaries where it was communicated that she needed that, printed, provided to the patient so that could be presented to a pharmacist in a way that sort of complied with their legal requirements to be able to give her that prescription.
So this is like a long story. This is weeks of going into the doctors, ringing A&E. Well, obviously A&E is so busy you can't get hold of them. And for somebody who doesn't know anything about, you know, how you go around getting any help, but in the end the doctor just said, well, ring emergency call line. Didn't give me no number. I didn't even know who I was speaking to. So I just Googled it and it came up with PALS and I thought, I've never ever heard of these people. So I rung them up and from there it was just absolutely brilliant.
When she contacted us, she was absolutely terrified. She felt as if she was going to revert back to how poorly she was before and was going to be back at square one and was going to have to come back into hospital. She was really, really anxious, really tearful, and following us getting that sorted, she explained the relief that she felt and how shocked actually she was that it could be sorted so quickly once we'd been contacted.
She was really lovely. Jade was. She said she'd ring back when she did ring back when she did promise to ring back. The doctors just weren't interested. So Jade went through a lot of things, getting different people because you're not allowed on the ward, but she kept relaying all the information back to us, what made us more, promising that she was going to do things. And it was just really a nightmare. And from when we rang Jade, it was like a big relief. I never thought it would be sorted out, but she sorted everything out, and she was really lovely. And they were really lovely to us where we were going in the doctors and things, and they were really unapproachable. They were really nasty. The lady at the reception folded her arms and said to me, "Do you know how this works, this doctors?" And I said, "Well, not really. It's my mother-in-law's doctors. She's 78. I'm trying to sort it out." But she was really horrible. And so I did put a complaint in about the hospital and at the doctors, but PALS have been absolutely brilliant. Nobody knows about PALS. Everybody I spoke to, I don't know what that is. And they were absolutely brilliant.
When you're at home and you don't know who to ring, you don't know who to turn to, and that's what we want to do. We want to make sure people know to ring and turn to us. When you're in that position, you're massively vulnerable, and we don't want anyone to be in that position. So hearing the change of her voice from panic to, I'm okay, this is sorted, I don't need to worry about it, I haven't got to ring all these people now and try and get somebody to help me, was brilliant.
Well, I'd definitely say go to PALS because they were amazing. I can't praise them enough. Where everybody else I've dealt with who you think would be able to do it, like the doctors and all these people would be able to do it, and they couldn't. And somebody I've never ever heard of was absolutely brilliant, but more people need to know, and I don't know how you go around doing that, but it needs to be put out there so they know that there is help.
I would advise everyone in the community, if they're having a problem, to contact us at PALS, because if we can't help, we know who can. And 9 times out of 10, if your care is under the trust, we can help. Even if that's not ourselves directly, we'll communicate with the people who can, and we'll make sure that what needs to happen does, and we will consistently make sure we're letting you know what's going on with that as well, so that there's one port of communication rather than you attempting to ring several people or contact several people to find out the answers that you need or to get things moving, and we'll advocate for that as well.
PALS are absolutely brilliant. They were lovely to speak to. They sorted everything out. We didn't have to do anything. Well, I was running around like an idiot, basically, here, there and everywhere and getting nowhere.
I think it's just really useful to note that we're a team that supports people. We really do support. We put ourselves in people's shoes, and we don't just look at everything from a clinical aspect. We look at everything from a person's aspect as well. So I don't want anyone to be fearful of being reprimanded for contacting us or not being treated fairly, because we are a really good team and we work really hard to make sure that everyone's supported. So we're contactable either by telephone or email or in person. So we're based, like I say, at both hospitals. We're through the main entrance of both hospitals, so we're very, very close. Our contact numbers are on leaflets surrounding the hospital and on our internet, and as is our email address as well. And in writing, it's just to the main hospital addresses, addressed to the PALS team.
Thank you, Kate. And while Kate goes back to the slides, I just wanted to highlight that some of the actions that you saw there at the end are things that have happened because of the person sharing their experience. So it highlighted to us that actually we needed to make sure that more people know about the PALS service, and some of the steps that we've taken to do that. We've also got an event coming up next week where we're looking at accessibility to the PALS service to make sure that people understand what it is, but actually are there any barriers to people accessing that service? And something else was around the importance of, or the impact of, not having a discharge letter when that patient went home and the stress that it put on her and her family. So that's something that we've taken to some of the meetings. So we've been to the emergency department governance meeting to share that with their lead nurses and doctors, and we're taking it to other places, other governance meetings too. It's going to a nursing meeting tomorrow, which normally gets about 60 people there, and they're all lead nurses. So just to make them aware of the impact that people's actions can have on a patient and their family. And something else that we're doing is for the doctor's training that's delivered with a focus on the discharge letters, is that we're incorporating that video now. So with the doctor that runs that, they've said that we can also attend and we can share that video so people can see the impact of their actions if they don't do it. So that's just a bit of an example. I mean, there were positives in there too. There was the fact that once PALS were aware, that they helped sort it out. But from our aspect, it's why did that happen in the first place? And how can we promote PALS so that more people can get that support if they don't know where to turn? If we can go to the next slide, Kate, if that's okay. Thank you. So I've just popped down some examples of things that we've done in response to feedback that we've had, but there are so many different things. This is just a snapshot, really. So the one is feedback we had from people, and that's what led to the development of speciality patient experience groups. So those are groups that work closely within different services around improving patients' experience. So they're actually making a difference. Making it easier for people to provide feedback. So making sure that we've got QR codes. We've now also, as well as paper, we would never get rid of paper too, but we're also in the emergency departments in the moment piloting a survey so that the friends and family test goes out by text to them. So it's how can we make it as easy as possible to let people know that they can tell us and share their experience with us. We've introduced longer visiting times, and that was in response to feedback that we had from somebody through a digital story. So visiting times used to be a couple of hours in the afternoon and the evening, and now they're much wider than that. So they're from 11:30 to 8 p.m. and the same visiting time is across all of the wards, so that if a patient gets moved from one ward to another, actually it's the same visiting time, and the people that are coming in don't need to worry about phoning that ward and finding out what a new process is. We've changed information or updated information on the website to make it simpler and to signpost people, and that's in response to feedback. We incorporate people with lived experience a lot more in training, and that's something that we're continuing to work on and is a priority. So we can do that through people attending live, through giving examples of incidents that have happened, and often through digital stories such as that, because it means that we can use them frequently. And it's easily accessible. And the other thing is establishing an independent complaints review group. So when I was doing a review of the PALS complaints and patient experience services, then it was highlighted that actually by responding to complaints, we're in effect marking our own homework. So how can we do that differently? So establishing an independent complaints review group was a way of having independent people look at some of our responses to complaints, look at the whole process and identify what was good and opportunities that we could have done better, and learning from that then goes forward into future responses. If we can go to the next slide, please, Kate. So how can people get involved? This is the exciting bit. So how can you get involved and help us? And the next slide, please, Kate. So I've mentioned the patient experience groups. We've got the speciality groups, and that's really where all the doing happens. So close working with people from those specialties. So we've got them for medicine, for surgery, children, young people, for clinical support services. So that's things like therapies and phlebotomy and pharmacy. So all of the different services have got speciality patient experience groups, and people from those areas work in partnership with patient representatives to review information that's coming in, to get more feedback, and to look at things we need to prioritise and drive forward with improvements. So those speciality patient experience groups feed into a more strategic group, and that's the patient and carer experience panel. So the patient experience and care experience panel, we call it the PACE panel because it's lots of words. So the PACE panel meet quarterly, and the speciality groups tell that PACE panel what they're doing. We've got action plans for improvement for each of the specialties, and it's actually that group holds them to account at moving things forward, to making sure that we're listening and involving people, and doing what we say we're doing to drive through improvements. That's chaired by the Director of Nursing, and it feeds into another committee that then feeds to board. So we've got a senior person that's chairing with oversight on that can support making a difference. So that's one way people can get involved. And the next slide, please, Kate. We also have stakeholder groups, and we've got some taking place next week. So there's 3 next week. There's one on PALS, which is the Patient Advice and Liaison Service, around the video that you just listened to. We've got one on the maternity service and one on the alcohol liaison service. So those stakeholder groups are an opportunity to listen to people in the community or people who work in community groups, stakeholders that work with those members that are accessing those services, to give us an idea on what we're doing well or what we're not doing well, how we could improve. So information will be shared with them, and we'll work together to identify how we're doing. And from that, we'll develop action plans to drive improvements. And we're really looking at that, at being inclusive. So actually, how easy is it for somebody with a disability to access those services, or how easy is it for somebody that perhaps English isn't their first language to access some of those services, so that we're making sure we're getting feedback from a wide number of the demographic in the community. If we can go to the next slide, please, Kate. So other ways you can get involved are with the Quality, Diversity, Inclusion, or EDI advocate group. So that's being reinstated. So it sort of went quiet for a little bit, and in the new year we're really going to be promoting that to try and move forward with some of the key work. So that will be looking at, again, where people have got specific needs, perhaps to access our services, to make sure that we are working through improvements, a little bit like the specialty patient experience groups, but this will be across the organisation, but supporting perhaps people that might have access problems because of a hearing loss or because of different reasons. So it's how we can do that. And that's another way people can get involved. And the next slide, please, Kate. So volunteers as well. So there's lots of ways volunteers support us. We undertake patient-led assessments of the care environment, more frequently known as place assessments, and that's a national system that happens every year. And that is about members of the community or patient representatives and volunteers telling us about what's good when they come into our services, or what's not, perhaps, if there's a barrier to accessing services, or what the environment is like for them. So that's one way people can get involved, and that involves visiting different areas. They test hospital food and they give us feedback on the hospital food too. We also have buddies within the chaplaincy team. So that's, again, a new system that's in place at Shrewsbury at the moment, and we're just looking to establish that and then move it across to Telford too. So that's, again, to provide additional support for the chaplaincy team who go out and see patients across the whole hospital. But actually, some people might benefit from a little bit more frequent visitors, or just some company for some patients. So establishing a buddy team to support some of those people that perhaps don't have that contact or people visiting them is proving very beneficial. And also for capturing patient feedback. So we've got volunteers that support with friends and family tests, with surveys and exemplar assessments, as I mentioned before. If we can go to the next slide, please, Kate. So the last way that I've got on these slides is for the readers group. So patient information is developed by a service, and then it's sent to through a panel, the patient information panel, and we will look at it, and we'll look at the reading age, and we'll try to make sure that it's understandable, that we're not using lots of big terminology, so that people, if this is given to somebody in the public, in the community, to make sure that it's information in a way that they can understand. So that's something that we do. But then what we also do is we send a number of those leaflets each month to the readers group. So that's people that volunteer from their own home. They get 2 or 3 leaflets a month, and then they send us feedback on those. So if there's areas that they didn't understand or it wasn't clear, they let us know, and then we take that on board before the final versions of leaflets are published. So that's another way of people can get involved. So the role of patient representatives and volunteers is fundamental, as you can see, through all of this work that we do. And we're really lucky to have a really committed team of people that support us in that work. But we are always looking for more people. So if there's people that are on the meeting today that would like to get involved, then we'd really encourage you to follow that through. And the next slide, Kate, please. So I would just like to invite any questions, which I think Julia will probably coordinate. Thank you for listening.
Thank you. There are some questions in the chat, and I did promise we'd take those first. Before we do, you said if people want to get involved, then you'd urge them to follow through. Is there an email address they can contact as a first point in order to make those initial inquiries, Ruth?
So it's by the website, and I'm happy to put some links in. I can put some links into the chat, or we can send them out afterwards. So there's a link to the specialty patient experience groups, which tells you a little bit more, and it gives you a breakdown of all of those groups and a bit of an explanation, because when I said about clinical support services, people wouldn't know that counted therapies, so it gives you a little bit of a breakdown, so you know what that means. And then there's also obviously the volunteers page as well. So we work closely together. So either route would get you to where you need to be. And I'll look at the links.
If you could put it in the chat, it just means that it's and perhaps while I give Ruth a minute to do that, just a little bit of interesting information. We talked about the PALS service, It's actually been around since 2002, and I remember that because Shrewsbury and Telford Hospital, actually it was just before we merged, we were one of the first in the country to sort of pilot the PALS service, and I know because I was the lead for it, and to me it was one of the most valuable services, and so difficult to get people to know about it. Once they do, it is, I've not heard anybody that hasn't been happy but with the service, that their job is to try to sort things out for patients and visitors, and they're not trying to squeeze it in with everything else. So if we could do just one thing to get PALS more widely known, would be a great bonus, really. I'll now go to the questions, although I think Vanessa's first one might have been answered by some of the later slides. But Vanessa said that your examples on the slides of how people can share their experiences appears to be mainly anonymised or gathered electronically. Often the face-to-face conversation can be the most significant. However, both inviting and accepting feedback, especially if it seems negative, can be difficult for staff. What is SAF doing to support staff to invite and respond to people's experiences of the care they've received from the ward or the departmental team? And I think you've covered that a bit, but if you just wanted to expand a little bit, Ruth.
Yeah, so we would always encourage, the first route is, and I think we've got this on the website as well. So if you look about on the website under where the PALS is and how to share compliments, concerns and things like that, what we would always encourage first is for people to talk to the staff that are there on the ward, or the ward manager or the matron, to enable people to have that conversation, to address a concern before it escalates, to make a difference rather than wait till you go home and things like that. The complaints team, if we receive a complaint after somebody has gone home, then they are very much encouraging meetings so that the person that's not happy, that's made a complaint, can have a meeting with the relevant staff to discuss what their complaint is and go through that. Digital stories, again, that's a way of meeting and capturing that feedback. So there's lots of different routes. We also do not a digital story but just a story, sometimes of a patient that comes to a meeting, to share that face to face as well. So it all depends on what the feedback is.
Not really what I'm asking.
Okay, sorry.
I'm saying it's about how confident the staff are to handle those difficult conversations at ward level when they happen. I mean, I am just so aware of the massive improvements that have happened in maternity since Ockenden, but I'm not convinced that good practice is spread widely across the hospital.
I mean, I think it's a very good point, Vanessa. One of the things that we now do as part of clinical leadership and management leadership generally is around sort of difficult conversations and about responding positively. My husband always says that he only makes complaints to places he values, because he wants them to, he wants them to improve. If it's a place he's not bothered about, he can't be bothered to complain. So I think it's about treating a complaint as a gift, and we do that. Is the ethos we adopt. It isn't all, and there's always a lot more that we can do. But I used to manage the complaint service, and certainly the defensiveness, and I think the independent review complaint group, which I think you mentioned later on, is a huge step forward, because in the past it did feel like marking your own homework, and there was almost a culture of, well, let's try to smooth this over and just move on. Whereas now I think I've seen staff really impacted by hearing firsthand about the impact of things, and it is a very powerful thing. We could do it better, but I think we are making steps in that direction, and it's by trying as much as anything to it's not about either shooting the messenger or blaming it's about working together, and I think that's what Ruth and her team really try to do to create that collaborative and environment that you can have those sorts of conversations.
Feel safe to share.
Absolutely. Yeah. Okay, thank you. The next question, I will come to the hands up, but I did promise I'd do the questions first, because there's put up first. Peter said, consider issuing surveys to a sample of patients prior to an appointment. This way, a patient would be assessing the service, knowing what they will be asked to comment upon during the process. This could increase the quantity and the quality of the feedback.
Okay.
So
something we can look at, absolutely. Yeah. It's just a different way of doing it, but we can absolutely look at that.
Yeah, so that the patient can see it with the eyes of what the survey might be asking them about, rather than trying to remember it afterwards. It might also be a useful prompt as well for staff to know these are the things that are important to patients. I mean, it was interesting, the slide you showed about what mattered to patients and what didn't matter to patients. I was very surprised to see that what didn't matter to patients was convenient car parking, because every meeting I go to I get that's raised. So I was pleased to see it on your slide, but I don't think it's borne out in Shropshire. But yeah, thank you, Peter. Ruth will take that away, and we'll look at doing it sort of prospectively rather than retrospectively, which I think is what you're saying. Vanessa wants to commend setting up the independent complaints review group. Really important that the letter sent to complainants actually address the issues raised. Far too often in the past, these letters have focused on the clinician's views and are often covered up matters important to the complainant with medical jargon. And I think, if I'm honest, Vanessa, it wasn't. I think clinicians see the world from a clinical perspective, and it's not deliberately to obfuscate, but until you hear the story that we heard earlier about the discharge letter that didn't get sent, you don't actually realise what impact it might have had on somebody. So I think it's not because they don't care that it didn't go, it's just that you wouldn't have realised that it would take weeks and weeks to get it sorted out. So I think by feeding it back whenever we can, the consequences of what might seem like not a huge thing. I used to deal with medical negligence claims, and when I did induction with for the junior, I used to say, for some people, coming into hospital is a once in a lifetime experience. They will remember everything you say, every throwaway remark, every detail, whereas you will say something and not even remember it. So you do have to be so mindful that what you say will be hung on to and taken as the absolute, and it may not have been meant in that way. So please be very mindful. And one of the earlier slides was around communication, and you can't overstate that. Having been on the other side and being a patient, you do feel so much more vulnerable in that position. And I've worked in the health service for 38 years, but sitting there in my 90, I said, you do feel disempowered, and you do, it is hard to challenge. So I think it all comes back to communication. So I think I agree with Vanessa. It is a really important step forward. And I think, again, it's part of this whole approach that we're trying to take, which Vanessa mentioned in maternity is sort of a leading example, really.
So can I just add to that? So we do link, although we're a small team, obviously we link in with other teams across the organisation, and one of those is the education team as well. So communication is one thing that we're looking at, and how we use examples and feedback that we've received from patients as scenarios to work through communication styles as more of sort of a discussion, really, rather than just being talked to. So that's something that we're working through at the moment.
Thank you. And then there's about 3 links now. Everybody's been putting in links to patient experience, so it's all there. But Jenny asked in between the links, has the preparation for colonoscopy leaflet been updated with British rather than American food? And I don't know the answer to that. My brother, I don't know.
I don't know, but what I can do, because we have so many leaflets, if the name of the leaflet is in there, or if you've got any more information, I can put my email address in, then I can go and I can look at that individual leaflet. So I'd appreciate that feedback. Thank you.
Okay, thank you. Thank you, Jenny. If you don't mind, that would be helpful, and we'll have a look at that, because there is a vast difference between the transatlantic diet. And then lots more email addresses, and I think that's all of the comments. So I will now go to the people patiently waiting. And Naz, I think your hand was up first.
Thank you very much, Julia. Nice to see you, everybody. My quick feedback was that in the last 2 months, that a friend of mine was injured we just left McDonald's retail park in Wellington, and he lost his footing and tripped over and banged his face on the footpath and was injured. So the experience from there was that the girls had come out, cleaned him up and tried to do the best. And the ambulance was going to be a long time. So I grabbed him and took him into my car and went to A&E. And the experience what we had was in A&E, obviously it was absolutely packed out. We still waited. I waited with him throughout the whole process. We attended the nurse, triage nurse. And then when he came around to seeing the doctor in the A&E area and the nurse in the booths, they were excellent, absolutely excellent. They could understand that my friend was 79 years old. He was elderly, and the injuries that he sustained on the top of bridge of his nose, they felt that instead of making him wait all that long for hours and hours and more, they put some stitches up, they cleaned him up like and all that, and felt that it was a really excellent service really from them. Instead of making us, we could have waited a longer time, and it wasn't that we wanted to wait, but if we had to wait, we could have waited like that. But I just felt that sometimes you get that negative thing about A&E and everything, and I just felt that experience what we had was excellent because I went through the whole process, and then when we left hospital, I did take him back home as well.
Oh, that's very good. Very good.
That was a positive experience.
Thank you.
Experienced that in A&E, very, very busy. It was absolutely chaotic in there. We waited our turn, and once we got our turn, the doctors could understand his injuries like and that and how he done it. So I was grateful that and very appreciative for the nurse and the doctor to have thought of about the patient who was 79.
Yeah. I mean, you make a very sort of valid point. Patient experience is about the good as well as the bad, because a lot of our patients have really good experiences, and it's learning from those and how we can replicate that as much as it is learning from the more negative experiences and how we can improve on that. So it's a bit like somebody said that, if anybody ever says to you, oh, can I give you some feedback? Your heart usually sinks because you think it's going to be negative, and actually it isn't. We should be better at, can I give you some feedback? That was a brilliant presentation.
Well,
that sort of thing, rather than the negative. So thank you for that.
The reason why I give the positive feedback was considering it was packed out at A&E. The doctors were always under pressure, how busy it is like that. And I just felt that they did an excellent job. Thought about the patient. They could have made the patient wait a little bit longer and go to the next booth or do some other tests and that. But I think they did the right thing and thought about the patient, which was a very positive point.
Excellent, and I hope your friend. I hope your friend's all right now.
He's absolutely brilliant, and the experience was really good. So I had to relay that. But my own experience is today, so I have to relay that to you as well. My own experience was today. I did attend Princess Royal Hospital today.
Naz, if what we did say earlier on is actually we weren't going to get into personal, because this is being recorded, and I don't, so thank you for the positive feedback about your friend, and I'm also very conscious that we're now at 29 minutes past 7, so unless there's a burning platform that anybody wanted to raise, I am going to make that the last comment rather than question. I am going to, on behalf of everybody, thank Ruth for a very interesting and helpful presentation, and I thank everybody who put the comments and the links into the chat, because they're all there for you there now. We will be putting this onto our website, so you will be able to watch it again if there's anything that you missed. And as Ruth said, if there's any of the areas that she's mentioned where you would like to get more involved, then please do contact Ruth and her small but growing team. I'm sure they'd be delighted to hear from you. And as I'm probably not going to see most of you again before the end of the year. I wish you all a very Merry Christmas and a Happy New Year, and see you next year. Thank you very much and good night.
Thanks.
Thank you.
Cheerio. Bye now.
Thank you.